The morning Dr. Harlan Reid delivered his assessment, the room smelled of cold metal and recycled air. Margaret sat in the chair across from his desk, the kind of institutional chair with no armrests, designed to communicate that your time is limited. And she watched him lay a manila folder flat on the surface between them, as though placing a verdict before a jury that had already been dismissed. He did not look up when he said it. The phrasing was careful, measured, and utterly final. The Pontine location rendered any surgical approach anatomically contraindicated. Radiation would be offered. Palliative management could be arranged. There was no cure. She did not cry. That is the first thing I noted when I opened this file. Most accounts preserved in this archive describe the collapse that follows a sentence like that, the way the room tilts, the way fluorescent light becomes unbearable, the way a parent's hands lock around the edge of a chair until the knuckles go pale. But Margaret's hands, according to the attending caseworker's notation, were still. Her son Thomas was 7 years old. She had driven 40 minutes through early November sleet to sit in that chair. And when Dr. Reid finished his clinical summary and placed the pen back in the breast pocket of his coat, she reached into her own pocket, not for her phone, not for a tissue, but for a worn, laminated card, no larger than a business card. The image printed on it was Saint Jude, Thaddeus, patron of desperate causes. She held it flat against her palm, the way someone might hold a compass. I am Claire. Tonight, we unseal a documented case that has been sitting in a verified archive since the winter of 2008, a case that concludes not in the language of oncology, but in the language of something that oncology, at its most honest and its most precise, simply cannot account for. I have held this file for some time before bringing it here. It deserved that consideration. Thomas had been symptomatic for 11 weeks before confirmation. The first signs were small enough to dismiss. A slight inward drift of his left eye that his kindergarten teacher noticed during reading time. A morning headache that Margaret attributed to screen time during a long weekend. Then the ataxia came. A lurching, wide-based walk that looked, to anyone who didn't know to look for it, like a tired child coming off a long run. By the time a general practitioner ordered an initial brain scan, Thomas had already lost 8% of his body weight across 6 weeks and could no longer ride his bicycle without steadying himself against the handlebars. The imaging report came back on a Tuesday. The radiologist's impression read, heterogeneous T2 hyperintense infiltrative mass centered within the pons, consistent with diffuse intrinsic pontine glioma. Biopsy deemed non-contributory, given anatomical confinement within the brainstem. Histological grade assumed 4. Diffuse intrinsic pontine glioma carries no curative treatment. This is not pessimism. It is a structural fact of medicine. The pons governs breathing, swallowing, and the basic continuity of consciousness. No surgeon can enter it. The tumor does not grow around the brainstem. It grows through it, threaded into the tissue that keeps a human body alive. Dr. Reid had delivered this information to 11 families before Margaret. He had learned to be precise, because precision, in his estimation, was the most honest gift he could still offer. There was no ambiguity left to give false comfort to, and no ambiguity to withdraw later. What he could not have known, and what the official caseworker report documents, but does not explain, is that Margaret had begun a private novena to St. Jude 3 days before the diagnosis was confirmed. Not after the verdict, before it. She had felt, in the way she later described to the parish priest who co-signed the attestation included in this file, that what was approaching would require an advocate beyond the reach of the available options. So she had already started. If this archive is reaching you tonight, and something in you recognizes what Margaret understood in that waiting room, consider subscribing to this channel before we continue. These cases are preserved here for the people who need them, and subscribing ensures you receive them. Now back to the file. The early treatment protocol was standard and delivered without ceremony. 6 weeks of external beam radiation to the Pontine region, 5 days a week, with corticosteroid coverage to manage the cerebral edema that radiotherapy predictably produces. Thomas lost what little appetite he had retained. He slept 14 hours a day. Margaret kept a handwritten log of every session in a spiral notebook she bought at a gas station before the first appointment. The notations were spare and clinical in their own way. Date, drive time, Thomas's mood, what he ate, whether he kept it down, and one line she added to the bottom of every entry, whether the morning prayer card routine had settled him. She would hold the Saint Jude card in her left hand and his hand in her right, seated in the radiation waiting room before each session began. The radiation ended at the close of week 6. Post-treatment imaging was ordered 14 days later. The attending radiation oncologist reviewed the results and documented a partial radiographic response. The lesion had not grown measurably during the treatment window. In the discharge summary, this was phrased as stable disease. In the context of this diagnosis, stable disease represents the ceiling that radiation was designed to reach. It does not mean improvement. It does not mean recovery. It means that the known conclusion had not yet accelerated. By month 3, following diagnosis, Thomas was referred to a pediatric neuro-oncology specialist at a university hospital 50 miles from their home. The consulting physician ordered a repeat MRI. The imaging showed interval progression. The lesion had enlarged along the dorsal surface of the pons and now demonstrated early involvement of the bilateral middle cerebellar peduncles. The corticospinal tract signals on diffusion-weighted imaging had deteriorated. The specialist's summary was unambiguous: disease progression despite completed focal radiotherapy. Further curative intent intervention, none available within established clinical guidelines. He was not without compassion. He explained to Margaret that investigational trials existed, that the science was moving. But Thomas did not meet the eligibility criteria for 2 of the 3 active protocols. His disease had progressed past the stable baseline required for enrollment. The 3rd trial required molecular subtyping through a biopsy, and given the Pontine location, the procedural risk was judged to exceed any reasonable benefit. The trial coordinator mailed a formal ineligibility notice. Margaret received it on a Thursday, placed it in the manila folder behind the original diagnosis report, and did not allow Thomas to see her open it. It is a heavy truth to witness a proud system reach its own absolute boundary. The ledger teaches that the valley must sometimes be walked in full before what follows it can carry its proper weight. I say that not as comfort, but as the single structural observation that makes this particular file worth preserving. Because Margaret was not passive in that valley. She drove Thomas to every follow-up. She administered his corticosteroid taper as prescribed, 12 milligrams of dexamethasone daily, reducing by 2 milligrams per week, and tracked the edema symptoms in the spiral notebook, 1 page behind the radiation log. She was the most organized presence in every clinical encounter she entered. The nursing staff noted it informally. The residents observed it. None of it appeared in the chart because it was not clinical data, but the attending physician recorded it later in a sworn statement contained in this archive. She seemed to understand what was happening to her son with a clarity that was almost uncomfortable to witness. Bevacizumab was attempted off-protocol in the 4th month. It is an anti-angiogenic agent. It targets the blood vessel formation that sustains solid tumor expansion. It had shown modest and inconsistent results in adult high-grade gliomas and was being used compassionately in pediatric cases where all standard options had already closed. Thomas received 4 infusions across 8 weeks. The response assessment at week 8 documented no objective radiographic improvement. The tumor had continued its infiltration. The diplopia, the double vision that had been present since week 3, had worsened to the point that Thomas could no longer read the prayer card on his own. Margaret read it aloud to him every morning before the hospital transport arrived. By week 17 post-diagnosis, the full clinical record documented one coherent conclusion across the assessments of 3 institutions and 6 consulting physicians. The official oncology discharge summary, co-signed and dated, carried a final notation at the bottom of its assessment column. No further disease-modifying therapies available within current standard of care guidelines. Best supportive care recommended. Family referred to pediatric palliative services. The caseworker assigned at that point was a woman named Sister Bridget from a religious congregation that partnered with the hospital's palliative unit. Her case notes form the second half of this archived file. They contain an observation that no physician's chart had recorded. Margaret had not missed a single day of the novena, not one, across radiation sessions, infusion waiting rooms, and a clinical trial rejection arriving by post. Every morning, the prayer card, the rosary, the petition to Saint Jude. Every evening, the same. If the weight of this account is sitting with you, take a moment here. Subscribe to this channel. These documented cases exist for people who are in the middle of their own version of month 4. And subscribing ensures that the next file reaches you when it does. What comes next in Thomas's case is the part that none of the attending physicians in this archive has been able to explain in writing to this day. You know what the final clinical notation read. You have seen it. No curative intervention documented. Prognosis, terminal. Supportive care indicated. Now read that sentence one more time. Not as a family member, not as a patient. Read it as the document itself. Read it as the written consensus of the most advanced diagnostic and therapeutic systems available to a child in a northeastern United States hospital in 2008. Read it as the record of what organized human medicine built, funded, tested, and ultimately exhausted, and still could not do. That notation was not the end of Thomas's story. It was the condition his story required. The ledger does not operate through sentiment. It operates through elimination. When a case is documented here as carrying an outcome that defies the clinical record, it is not because something inexplicable happened alongside the treatment. It is because the medical record itself has first produced a clear, multi-physician, multi-facility, written confirmation of total therapeutic exhaustion. The surgeons who called the tumor inoperable were not wrong. The radiologists who documented progression were not wrong. The oncologists who closed the protocol window were not wrong. They were right, completely, verifiably, documentably right, each one of them. And that completeness, that institutional consensus arriving at 0, is the precise structural condition the ledger requires before it records what comes next. For those who carry the traditional faith, you do not need me to explain what I am describing. You have held prayer cards in waiting rooms. You have whispered petitions under fluorescent lights, while someone in the next room reviewed results that confirmed what you feared. You know what it means to reach the place where what you can do has ended and what you believe must begin. For those who carry that faith, an unexpected turn is never coincidence. It is the quiet, careful signature of intercession. That is not this channel's opinion. It is the theological position that frames every file in this archive, and the lens through which the evidence in Thomas's case must be read. What happened to Thomas in the 17th week of his illness was not predicted by any member of his clinical team. It was not consistent with the documented natural history of his diagnosis. It was not attributable to any pharmacological agent present in his bloodstream at the time. The neuro-oncology team would later classify the event using a term that appears in oncological literature at a frequency of less than 1% across all solid tumor types, and which had never, at the time of this file, been formally documented in a peer-reviewed case study of diffuse intrinsic pontine glioma. Not once. What the attending physicians saw on the follow-up MRI ordered on the morning of day 19, 2 days after the conclusion of Margaret's novena, requires its own account. That is where we are going now. The morning of the imaging, Thomas woke up and asked Margaret for toast. Not the nutritional supplement the palliative care nutritionist had recommended. Not something soft. Toast. With butter. He said the word clearly, and with an appetite that had not been present for 9 weeks. Margaret did not call the hospital. She made the toast. And then she noticed something she had not observed in 2 months. Both of his eyes were tracking together. The diplopia that had appeared in every clinical notation since week 3 was gone. Both eyes, forward, aligned. The attending nurse documented it in the daily chart. Patient demonstrates bilateral ocular alignment without assistive correction. Confirmed on examination. No change in current medication. The attending physician was notified. A repeat MRI was ordered, not because any clinical rationale existed to expect change, but because the nursing finding was sufficiently anomalous to require objective documentation. The scan was completed that afternoon. The radiologist called the neuro-oncology fellow directly, rather than routing the report through the standard filing system. That deviation from procedure is itself in the record. The fellow was handed the imaging without preface and asked to describe what he saw. What he saw was a pontine lesion measurably reduced in T2 signal intensity in volumetric footprint compared to the prior imaging 18 days earlier. The bilateral corticospinal tract deterioration, documented on the previous diffusion-weighted sequence, showed objective improvement. There was no new enhancement, no hemorrhagic conversion, no artifact that could reconcile the discrepancy between the two studies. The radiologist's final impression on the written report included the phrase, "No interval pharmacologic or therapeutic intervention documented to explain the finding." Dr. Reid was contacted and asked to review the comparative imaging. He reviewed it alone in a radiology reading room at a teaching hospital 40 miles from where Thomas was admitted. His formal written response to the neuro-oncology team, preserved here in its entirety, is 7 sentences long. The final sentence reads, "The degree of radiographic change observed between the two studies is inconsistent with the documented clinical course of this tumor type and inconsistent with any intervention present in the patient's current pharmacological record." No further clinical explanation is offered. He did not call it a miracle. He was not in a position to. But he was also for the first time in this file's documented record, without a framework that could contain what the imaging showed. Margaret was in the room with Thomas when the attending physician came to speak with her. She was holding the Saint Jude prayer card, creased down its center, from being folded and unfolded across 19 mornings. The physician told her what the images had shown. He told her it was unusual. He told her the multidisciplinary tumor board would review Thomas's case the following week and that they would continue to monitor closely. He used the word encouraging. Then he left because he had other rounds and because nothing in his training had prepared him to remain in that room any longer than the update required. Thomas was discharged 22 days later. The tumor board's documented consensus: spontaneous, partial radiographic regression, mechanism unknown, no curative intervention on record. That is how this file closes. Not with a theological declaration, not with a medical retraction. It closes with a column of clinical facts that cannot be made to add up, and with a woman sitting beside a hospital bed holding a laminated prayer card, while her son asked for a second piece of toast. These accounts are preserved and narrated here for the people who have sat in the same kind of chair Margaret sat in, the institutional kind with no armrests. The ledger exists to tell you that what those chairs communicate is not always the final word. If this account found you tonight, in a moment when you needed it, share it. Let it reach someone else in a waiting room. And if you are new to this archive, subscribe, because there are more files. There are always more files, and some of them were preserved specifically for you.